so I could envision in my mind if there was an event in PACU that if we were completely jam full, that we would utilize pre-op nurses to help draw up dantrolene, and go through things, because you need like a ton of hands on deck. So I think it's really useful information to have, so if there was ever an event at our hospital, that we could all be knowledgeable. And there's a huge pre-op portion that I know you guys already do with the pre-screening phone calls. So let's get started. So what is malignant hypothermia? It's a potentially lethal syndrome. It's a chain reaction event triggered in susceptible patients by commonly used general anesthetics that we're going to review. So it's a hereditary abnormality of the muscle metabolism caused by certain triggering agents resulting in threatening pharmacogenetic disorder. So what are some of the triggers that cause people to have a malignant hypothermia crisis? So the depolarizing muscle relaxants sucks, which we talked about. So there's two categories for muscle relaxants. There's your non-depolarizing, Rock and Beck, and then there's your depolarizing muscle relaxants. And the only depolarizing muscle relaxant out there is sucks. So that's one triggering agent. The other triggering agent is the volatile inhalation anesthetics. So there's some example of them up there. But usually what happens is a combination of both when you have patients have had sucks and they've also had the volatile inhalation agents together, which can, if they have that genetic trait, can cause an MH crisis. So just to talk about sucks just for a second, because it's an important drug that does not, and so as a reminder, the depolarizing muscle relaxants do not have a reversal agent for them. So when someone gets sucks, if they are susceptible to getting MH from it, then there's not like we can give a reversal agent immediately to kind of counteract the sucks. So it's a depolarizing muscle relaxant. The reasons they use sucks is for airway emergencies, if there's any risk of aspiration, and it's routine use in elective surgeries for kids. Questions about sucks, depolarizing, non-depolarizing agents that we talked about? So the other trigger for an MH crisis are the volatile inhalation anesthetics that are listed there. And so like sevoflurane we use all the time on kids. When like all the Dr. Hubble cases are all done under sevo, like a lot of them are done under sevo. So we definitely use ISO here, DES, sevo, all the time. So there are some safe options for these patients. They can have surgery without complications. They can have a non-depolarizing muscle relaxant like Rock or Beck. Benzos, like Midaz, diazepam, lorazepam. They can get the nitrous oxide because nitrous oxide falls into a different inhalation gas category of this gasish agent. So it's a non-volatile inhalation agent, so it is safe for these patients. Ketamine, etomidate, propofol, those are all safe options. So usually what they do, if it gets flagged at all during your pre-screen phone call that there's a family history of MH, they just usually use nitrous oxide so the patient can still be intubated, and then they'll just use like ketamine, propofol, and Rock and Beck. So the pathophys is going to go over the next 3 slides. It's really wordy. I'm going to try to make it so it makes a little bit of sense, but it's even confusing for me. I was trying to like pull up a video and I couldn't even find a good video yesterday. So a patient's susceptible, then they get exposure to one of the triggering agents, so sucks, or to the gas, which causes a sustained release of calcium. So calcium just floods the gates. At the same time, massive consumption of ATP and consequently hyperactivation of the respiratory producing heat. It's going to make sense in a second. Which then, since calcium is free flowing into the cell, despite maximal energy production, the muscle cell can't clear the calcium and muscle rigidity occurs. As the body burns carbohydrates and fats to produce ATP, excessive heat is generated, leading to hypothermia. Simultaneously, excessive CO2 is produced, leading to respiratory acidosis, and when aerobic metabolism is overwhelmed, anaerobic metabolism occurs. Accumulation of lactic acid results in metabolic acidosis. Wow, that's a lot of information that we just are never going to be able to just like remember like that. But how we can kind of break it down, and what's more important for us is to know what the signs and symptoms are of this whole chain reaction that takes place. So one thing we can kind of keep in mind based on this whole reaction is the patient usually starts off with respiratory acidosis, which then leads to metabolic acidosis. And as a reminder, respiratory acidosis, I like these little drawings because your pH is going to drop, your CO2 will increase. These things take place, so your blood pressure usually drops because you're vasodilating. You're drowsy, you're disoriented, and then it leads to metabolic acidosis, which has the effect on the kidneys. Your pH is low, warm flush, muscle twitching, changes in LOC.
Changes in what?
Loss of consciousness.
Oh.
Questions about this? Kind of confusing. Then cellular function is compromised and cell damage occurs. So the muscle cells disrupt, releasing protein and potassium into the bloodstream. So like too much potassium can lead to cardiac arrest. So it's a long process, pathophys-wise, and kind of confusing. So let's just talk about what we can do and what makes sense for us. So for prevention, you know, the best way to prevent MH is through detection of those at risk prior to surgery. There's a muscle biopsy that they can do on patients if they suspect that they are, people have been studying, if they suspect that they have the genetic gene, but insurance doesn't cover it, and it's only in certain hospitals in this country that they actually even do the procedure. So they take a part of the muscle out, they send it through, they expose it to something similar to like what MH exposure
I think it's
would
called
be.
the caffeine halothane test, so must be there's exposure to that, I
It's
guess.
exactly what it is, and then they'll see if the muscle reacts or not to that exposure.
Yeah, bigger than
So, but yeah, it was like really expensive and insurance doesn't cover it. So really, what the best way to kind of prevent these is just asking the questions, you know, educating the community on it. And then of course, if it ever gets flagged, especially for you guys, you are a really important part of this because you have the communication with the patients. If the patient was to ever say anything to you guys, it would absolutely want to be communicated to anesthesia so they can change their plan and be prepared if the event was to take place. So everyone should be screened for family history of malignant hypothermia. Some questions that I'm sure you guys already asked patients, unexplained deaths or complications arising from anesthesia. You know, sometimes people have family members, like their grandfather died during surgery and they don't know why that happened. Well, maybe it was an MH crisis and it just never got, you know, it was 50 years ago and there was no, you know, follow-up conversation about it, or they just didn't know, and because it wasn't until like the 1970s that it became, we started educating providers in the community. So, so any unexplained death, personal history of unexplained high fevers or darker colored, cola-colored urine.
What's the dark colored urine from, do you know?
It's the breakdown of the muscle cells, yeah. Any episodes of heat stroke, family or personal history of any muscle or muscle neuromuscular disorder. There's, and I should have put them up here, but there's a list of neuromuscular disorders that sets people up for being at higher risk of having an MH crisis. So, what would we potentially see with a patient that's having an MH crisis? So, say this was happening in the OR, the patient's intubated. Usually the first sign, it all unfolds really fast. We say that like the high temperature is a late sign, but really that happens like, it is a later sign, but it happens pretty quickly in this process. So increased CO2. So when a patient's intubated, they're hooked up to the anesthesia monitor. The anesthesia provider's watching their CO2 levels. Their CO2 will shoot up pretty aggressively. And then followed by that, shortly afterwards, will be ventricular dysrhythmias on their monitors. And tachycardia. And when I say tachycardia, I mean the patient's like chugging away at 80 and now all of a sudden they're like 200. So it's like extreme tachycardia. So CO2 increase, tachycardia. If the patient wasn't in the OR and they were just, say in PACU, then it would be the tachycardia we'd pick up first because we don't monitor people's CO2 in PACU. And then even further out, if the patient had gone to the floor or gone home, then it would be probably the tachycardia that would get picked up first. So shortly after that, then because all that calcium is free flowing into the cell, the muscle cell will have rigidity, so it's usually sustained contraction of the jaw muscle. So like in the OR, when they have their ET tube, they're either, if they had just gotten sucks and now they're gonna intubate, it would be really hard to intubate them because their jaw would be contracting. And or if they had already been intubated, then they could potentially be biting down on the ET tube because this muscle right here is just gonna tighten right up. And so it'd be hard for them to open or close their mouth. And then generalized muscle rigidity can take place. And then fever is that later sign. So any rise in temperature greater than 0.5 degree per hour should raise suspicion for MH. You know, when I think of MH and I think of some of the patients I've cared for, if you have someone that gets tacky and doesn't feel so good and then gets a high fever, it can also be a sign of like someone going septic on you. Mm-hmm. So it's kind of, it's when I think of that, like a patient that goes septic is kind of like has those symptoms, but they're a little bit more controlled, versus an MH is going to be very fast and aggressive, and their symptoms are going to be really extreme. So elevated temperatures might be a later sign. A temperature as high as 117 has been recorded, but 111 is probably the highest with survival. So the reason they get the high temperature is because excessive heat production related to the skeletal muscle hypermetabolism. Other signs and symptoms that we potentially could see: brown or colored urine. It's a result of the breaking down of the muscle fibers and its excretion. Flushing, mottling, cyanosis, diaphoresis. These people aren't going to be hemodynamically stable. They're going to be yttric. So there's this great web page. I'm not going to pull it up right now, but I would recommend to, in a couple days from now, a week from now, pull up this web page, and it will kind of reinforce some of the, it's a really user-friendly web page about and used for providers, for families, around educating folks about MH. So there is a hotline, so in the event of a crisis at our hospital, anesthesia might want you to call the hotline. I've never called it before because I've never been in an emergency, but I'm guessing they give guidance around, you know, the protocol and what drugs to give and labs and everything you need to do. But check out the webpage because it's really, really helpful.
Do they have like a poster in the OR or something like that?
Yeah, I'm going to show you that in just a second here. So some post-op considerations. This is going to be a code. We're going to need to get anesthesia on board. And then there's a lot of collaboration that takes place. And then there's a lot of delegation that takes place with additional staff. So this is where I can see you guys coming in if this was to happen in PACU. Because we need the MH cart, which I'm going to show you a picture of. We need ice, so people just filling up buckets of ice. Cold sterile saline. There's a cooling blanket that we need to get. We need to get the crash cart, and then people need to start mixing dantrolene. So in the MH cart, if you go into internal control, does everyone know where the Pyxis is in internal control? When you have a moment, go into internal control, where like the fishbowl looking OR nurse's station is. right on the other side of the wall, there's the Pyxis, and right next to the Pyxis is the MH cart. And I think it's valuable to just take a stroll through there when you have a moment so you can see where it lives. And then immediately next to that, so the MH cart looks like it doesn't look like a code cart. It's like white and it has blue drawers. But it should never leave this specific location unless if there's an event. And then right next to it is the hypothermic blanket machine. So some standards that have been put out there is that our cart, and this is an expectation, that there's 36 vials of dantrolene in the cart, and then at our hospital we have 38 vials kept in pharmacy. Dantrolene is extremely expensive, like $500 a vial, so we have to charge the patient for it. And the shelf life on it, I think, is 3 years? Yeah, 3 years. Some other things in the in the MH cart, there's bags of sterile water, because that's what we're gonna mix the dantrolene in. And then right on top, Verlaine, like you had asked, there's a binder. And that is the binder right there on top of the cart that has the protocol in it and all the drug concentrations and everything. So this is what the cart looks like. Top drawer is your dantrolene. Your next drawer down is your 60 ml syringes with your 18 gauge needles, mannitol, and then your fourth drawer down is supplies, and then your last one is Foley catheter. So that's what the kit looks like, or that's what the cart looks like. It does need to be cracked, so it's typically locked so no one takes supplies out of it. Just another picture of the cart, and then next to it is the hypothermic blanket machine. So dantrolene is the therapeutic agent that counteracts the effects of MH. So how it works is it acts by blocking the release of the calcium from the skeletal muscle cells. So it doesn't like wash away the socks or get rid of the gases. All it does is acts by blocking the release of calcium. It's in the MH cart by the OR, and then more is kept in pharmacy. There's also another cart at the Fanny. And at the Fanny, the cart is kept past the point that we're allowed to go into. So it's like in a sterile area where you would have to have scrubs on. So I was talking about it with my office mate, Kristen, who works over there a lot, and I was like, can we just go in? If it's a real emergency, guess what? I want that cart. And she said, yeah, absolutely. If you're in regular scrubs and it's an emergency and you need the cart, go in and get it, and it's totally fine. No one would harass you for it. So reconstitution of dantrolene is very labor intensive. This says you need at least 2 nurses. I think you need like 6. But that's my own personal opinion, because if I'm the patient, I want to know that you're all mixing dantrolene together. So you need 60 cc's of sterile water mixed into the ampule using an 18 gauge. And to dissolve it, it takes like 2 to 3 minutes. And we're going to all practice it here in a second, so you'll know why. So just to give you a sense of how many vials it might take to go through a patient. So most patients respond, so the initial dose per the protocol is 2 to 3 milligrams per kilogram, so they split it in the middle and always go with 2.5. And the ampule contains 20 milligrams. So if you had a 70 kilo patient, so 154 pound patient, treated with 2.5 milligrams per kilogram, they would need 9 vials as your initial dose. So that's a lot. So, and if it takes 9 vials, 2 to 3 minutes a pop to dissolve it, that's pretty labor intensive. So that's why I say more than 2 nurses. I say I want a lot of nurses on there because this needs to get this process moving. So I'm gonna demonstrate it now, and then I'm gonna pass this stuff around so you guys can start while I'm finishing up here on the PowerPoint, start mixing it. So what you guys all have are from 2006, so they're really expired. What I have here is expired 2010, so the newest packages look like this. Usually it's a powder, ours just with time has solidified, but you can still dissolve it. And then in the code cart is sterile water, or in the MH cart, excuse me, is sterile water. Make sure that it actually says sterile water and not some, like, normal saline or LR. And then there's these little connector pieces that are also in the cart, so you would have to spike the bag, take your 60cc syringe, alcohol, well, it would be sterile, so you wouldn't have to alcohol it. You're gonna draw up your 60 cc's of sterile water. If you get any air bubbles, you have to detach it, and, because you can't push back into this bag, it's a one-way valve. So if you got any air bubbles, you're gonna have to pop it off, push them out. So then you attach your needle, your 18 gauge needle. Then what the recommendation is, because of the pressure system involved, is to instill just a little bit, like probably do it like 4 times. Oh, no, I don't want to do that. Okay, don't do that. Although ultimately it's all going to be mixed together. So it's going to be pretty aggressive. Oh, that's not supposed to happen. So once it's all mixed, all the sterile water is actually in, then you're going to take it and you're going to mix it like this, back and forth until the solution is completely dissolved. You'll notice when you're doing yours today that it will take a lot longer because the solution is older, and it really actually takes the 2 to 3 minutes. As soon as this is clear in color, then it's usually good to go. And so then once it's all mixed, we would pass it to the anesthesia provider. They would draw it up, and then they're going to infuse it as a rapid infusion. So they're going to put it on one of their ports and just whoosh, push it in as fast as they can. When the next syringe is ready, they're going to do the same thing until they've gone through all their vials for their initial dose. Okay? So even this is not done yet because there's still some stuff floating around, so you want to just keep going.
Does it stay orange or does it turn clear?
It stays orange. Yep. Exactly. Okay, questions about that? So I'm going to send this around. I'm also going to send it around with some things so we don't make a complete mess. So that's dantrolene. Questions about dantrolene? Questions about mixing it? We good? All right, so I'm going to keep going here. So there is a new medication on the market. Dantrolene was the only drug for a really long time, but the new medication on the market is this Revonto. So Revonto has the same effect as dantrolene. Still reconstituted in 60 mLs of sterile water. The reconstitution is less time, it's only 20 seconds. And the shelf life is the same at 36 months. But Revonto is like super, super, super expensive. It's even more expensive than dantrolene. So I haven't reached out to our pharmacy here to see if we are, it's a newer drug only in the last couple of years. So I'm curious if we eventually will shift towards this. But for people that are staying for their certification, I know this could be a drug on the test. So, I mean, the big difference is it takes a lot less time to reconstitute, but it's the same idea. So for your additional nursing staff, so you need help with reconstitution, and then the other things that need to be done are bladder irrigation, rectal irrigation, pack the patient in ice like everywhere. The hypothermic blanket, it's a blue, looks like a blue yoga blanket, gets rolled out underneath them if you're able to roll them, goes underneath them, you plug it into the machine.
And that's a cold blanket?
Yep, because you want to cool the patient down.
And it's on them or under them? It's on them.
You can do either.
Huh.
Yeah. And then you're gonna be collecting, blood draws and every possible care you can think of is gonna be getting done for these patients. So cooling measures by packing bags of ice around the patient, cooling blanket under and over the patient, monitor their temperature. Yes.
Do you just use the ice from the machine? Or-
Yes, you can just use ice from the ice machines. Mhm.
Seems like they might like break. If you have, they don't.
That's why it's really labor
Hotel.
intensive, because you would send like a couple people maybe to 2 different machines and be like, with a big bucket, go at it, and just get ice.
Use the one by the kiosk. Especially around
So
lunchtime.
you're gonna continue to monitor their temperature. These patients are gonna be intubated, they're gonna get intubated if they're not already. So we can do an esophageal probe temp. And while you wanna lower their temperature, they recommend not going below 100.4, so 38 degrees Celsius. Some other cooling measures, cold saline through their IV, lavaging every possible orifice in their body, placing a Foley catheter. The anesthesia team will be working to correct that metabolic acidosis and respiratory acidosis. They're gonna insert art lines, central lines. They're gonna send blood, they're gonna send urine. They're gonna try to normalize their fluid volume. So just a few interesting facts. I always thought that if a patient got exposed to these triggering agents, that it was like a full-blown MH crisis every time, but after doing a lot of research this time, I found out that if they have just a little bit of the drugs, they can have a more mild reaction. So what a lot of the literature was saying is that like, people probably go undetected sometimes. They might have some of these signs and symptoms, but maybe it just was pushed aside as, maybe they were a little septic or another thing that we treated them for their symptoms, but we didn't really call it an MH crisis. So it'd be interesting what the number is on that.
It's too bad they didn't have like a borderline way to flag it, like
Flag
you had
it,
2
I
out
know.
of 3 of the symptoms and let's watch them next time, because they say it
Right.
could be more severe the next time if you got more of the drugs.
Absolutely.
A light anesthesia versus a heavier one.
Most definitely, yeah, that is true. And I found this really interesting, and I don't know how I didn't know this as a packing nurse, but it can happen up to 24 hours post-procedure. How scary, we're sending people home, and this can happen out in the community?
Yeah.
I mean, knock on wood, it doesn't seem like it has ever happened, but could. The cost of it's really high, and then the shelf life is 3 years.
How does the hospital come up with how much they need in case of emergency?
Yeah, so it's a standard, like a national standard probably put out by the MH organization that they have to have 36 vials in the code cart. And then I believe it's the 38 have to be in-house as backup.
And then is that the same at the Fanny?
Yes.
Didn't I read somewhere where different hospitals support each other? Like if you're going through a crisis, they help?
Absolutely, so all of like our network hospitals have that same thing. So if we had a crisis here, I'm sure someone would be getting in a car driving to CVPH or yeah, to get additional, but then you have to support that hospital, because if then they had an MH crisis, so it's kind of a shifting thing. But it all comes down to the money, that's why they don't wanna like leave a ton of this in hospitals, is because of the financial component. Because like happily, we don't use it, but then it's, wasted cost. But I was reading a thing, like the amount of money we pay on something else. I don't remember what it was. For medical equipment as an emergency thing, like just in case, was way more costly than us keeping dantrolene in our hospital. So it was kind of like, made me feel better about it. Go ahead, Noah.
Can you give too much and you have to keep checking calcium levels and stuff like that?
Yes, labs I would think would be happening hourly or something like that. I don't know exactly what the protocol is. And giving too much, I'm gonna say no. I didn't come across anything that said you could give too much.
So once the temp comes down, then they stop pushing the dantrolene, like where's?
So yep, great question. So they do the initial dose of the dantrolene and then they put them on an infusion for like 6 hours post that.
A drip?
Yep, like a, yep.
Huh.
So things that also need to be taking place as like a side note, this is a safe report, of course, situation. We need a charge for the dantrolene. I think you have to report it also to the MH crisis hotline or
Yeah,
something,
I
so
did
it
read
can
that.
be tracked, like they can look at data and everything.
Yeah.
So these patients can have a successful surgery experience if we do a lot of educating of providers, asking the questions, definitely ask the questions, and then everyone's educated on the protocol, so these patients can have a safe.
Have we ever had an event here?
I've never known of any event here in a long time. I think I was talking with Cece one day and she said like 15 or 20 years ago she had something.
Really?
And she said the first event that, or the first sign that she saw, it was in the OR, was extreme tachycardia, like extreme. And she knew it was the event and they ran it. But this was, I want to say it was like close to 20 years ago. So it doesn't happen very often. Yes?
Is it that you give the bolus and you can give another bolus until their temperature comes down and then you put them on the drip?
Because we're mixing all those bottles, one right after another.
No, I believe you do your initial dose and then you go to a drip. There's no correlation with the temperature necessarily. You're gonna be doing the other things to get the temperature down, like the cold blanket and those interventions, but that's separate from the dantrolene. The dantrolene is really just there to stop the calcium from entering the cell.
Can you do all 36 vials? What
Only
you
do for, so it's all weight-based.
Oh, wait,
Yeah, so you would just do,
Whatever
and
you
right
want
in
to
the binder that lives on top of the MH card gives the
No,
math and, amount that you should give.
gotcha.
Questions about any of this? So, the OR and PACU and Preop have all been educated in the last month on MH, so this is gonna be the perfect time if someone's coming through surgery and they're gonna have the event, it's gonna be right now, because everyone's gonna know what to do.
Do they do a mock MH crisis thing? I read about those.
Yep, they do them in the OR.
They do them in the OR?
Yeah. Yep. So it's, such a low frequency thing, but we have to talk about it because it could happen.
What's the closest ice machines? Obviously the PACU and the PPR?
Yep.
Where you go?
Yeah, definitely. PACU, PPR, SICU's not too far away.
They don't have an ice machine in the OR?
3. Downstairs in the lounge, I think they have an ice
Oh,
machine
wow.
down there.
Interesting.
Nice from downstairs.
It's very
Is
interesting.
there a list, like who delegates, like you print the labels, you go get ice, you're like, who's doing all, do they have that all written so somebody knows what needs to be delegated and?
Yep, there's a
you know,
list in the binder of things that need to get done. Anesthesia would run the event, but the primary nurse of that patient would be doing the delegating and
Good,
sending out. Good?
perfect, thank you.
Any other questions about MH?
Is there obviously must be ongoing research and stuff like that as to what the best,
Yeah.
Yeah,
There definitely is. I would think probably with the way drugs work, maybe in the next, hopefully my time frame, there would be a drug out there that would be cheaper.
Why is this not
Easier.
sold in like a big bag? I mean, the average person nowadays is like at least 200 pounds.
Sure. I think it just has to do with, like the
Stability of
chemical
it, maybe?
component.